We are so glad to have you all with us today for the next Global PrEP Learning Network. Today we are going to focus on reframing PrEP continuation, and various teams from the Prevention Market Manager, Jhpiego, and WHO are also going to share some thoughts on this and share out some findings from the think tank that PMM-Jhpiego and USAID have had on the topic of prevention effective use. My name is Christine Torjason. I am at FHI 360, and I'm part of the CHOICE team that is hosting today's webinar. We are pleased to have you here. Next slide, I think we have some housekeeping we can share. Oh, this is an overview of our talk for today. Next slide. Oh, I thought we had housekeeping, like how to use the chat and everything. Oh, that's down there. Okay. I got to get my things in order. So that we'll go back to introducing our today's speaker. So we're really thrilled to have Jessica Rodriguez with us. She is the Director of Product Introduction and Access at AVAC. She has over 15 years of experience in program management, strategic information, research, and communications, and has been working at AVAC since 2018, focused on bringing prevention options to those who need them most. She oversees several projects at AVAC that support the scale-up of biomedical prevention products. Jason Reed is with us from Jhpiego. He's a biomedical HIV prevention technical advisor, and he also has over 15 years experience in public health surveillance and medical epidemiology, specifically around HIV surveillance systems, biomedical prevention programming, and implementation research. He provides technical oversight of biomedical HIV prevention programs at Jhpiego, including PrEP for HIV, supports research development and analysis, and contributes to overall strategic planning. Next slide, please. We are thrilled to have Cindy Matze with us, who is the National Coordinator for Key Populations and PrEP programs in the Eswatini National AIDS Program Ministry of Health. Cindy is responsible for providing technical leadership and coordination, facilitating the development of policies and plans, and designing programs for key populations and PrEP programs in Eswatini. She is a nurse with extensive experience in public health and has a master's in public health as well. We also are pleased to welcome Nitya Panupak, who is the Executive Director of the Institute of HIV Research and Innovation in Bangkok, Thailand. She has a deep interest in key population-led health services, which empower key population lay providers who are members of key population communities to design and co-deliver HIV and STI services to their peers. She currently works toward the establishment of a national accreditation and domestic financing system for lay providers to ensure KPLHS sustainability. Next slide, please. And finally, we welcome Robin Schaefer from the WHO. He is a consultant for the Testing, Prevention, and Populations Unit of the Global HIV, Hepatitis, and STI Programs Department of the World Health Organization. He works on PrEP with a particular focus on simplified delivery of new PrEP products, and has a PhD in infectious disease epidemiology, and has worked on a range of global health issues, including sexual and reproductive health and malnutrition. So those are our 5 speakers today. We're so thrilled to have them. We also have some additional panelists with us. Josie Presley from the Bill and Melinda Gates Foundation, Rachel Bagley from WHO, here to just add to the conversation as needed. So here is the slide I was expecting earlier, just a little bit of housekeeping. We are hoping for an active chat. We have right now over 130 people on this call. But unfortunately, we have to have lines muted to allow for good sound quality with our presentations, but we hope to hear from you all in the chat. Please be sure to select the all panelists and attendees option in the chat so that everyone can see the conversation and participate fully. I think that's it. Next slide. I'm happy to pass this over to my colleague, Jessica Rodriguez at AVAC.
Good morning, good afternoon, everyone. My name is Jessica Rodriguez. I'm the Director of Product Introduction and Access at AVAC, and it's a pleasure to be here today to disseminate findings from a series of think tanks held by the Prevention Market Manager in collaboration with Jhpiego and with support from the Bill and Melinda Gates Foundation, as well as USAID. And these think tanks focused on exploring the notion of effective use for oral PrEP. How do we measure it? What does it mean for program improvement? What are promising strategies to support people to stay on PrEP while they continue to be at risk? And what are the implications for the delivery of not only oral PrEP, but the future of HIV prevention products? So what we really are proposing to discuss now is how we can apply next generation monitoring and evaluation for oral PrEP now, which is available today, as well as how do we think about M&E for the next generation prevention products tomorrow. Many prominent researchers, implementers, and policymakers attended the think tanks from a diverse range of countries and representing varying perspectives. And this webinar really consolidates the general consensus and findings that emerged from the think tank. And we're grateful to all of the think tank participants, too many to name here, for their contributions. Next slide, please. And this is an outline of what we'll be presenting today, which I reviewed. So next slide, please. Now, about a decade since oral PrEP was shown to be efficacious, implementation studies, some which are featured in this table, have shown that PrEP use declines over time and dramatically over 1 month. And this occurs across all populations and settings. And measuring PrEP impact at sort of a population level has been challenging, but as a result, are we judging PrEP by unfair standards? And so these trends around continuation have raised some concerns about the effectiveness of oral PrEP. But for a large part, the concept of retention and continuation have been a relic of HIV treatment programs, which have been transposed onto PrEP programs, and they might not quite fit. And so the think tank really explored how do we redefine continuation to be more appropriate for HIV prevention, and how do we measure it? And with prevention funding plateaus and potential declines, understanding and demonstrating impact will become ever more critical. Next slide. So a few key themes emerged from the think tank, the primary being that we really must reevaluate what we mean by continuation and effective use, and it should reflect people's lived realities and how they actually use PrEP now that we have an abundant amount of evidence from implementation. And I mean, I'm sure as everyone knows, effective PrEP use does not have to be continuous over consecutive days. It can be event-driven, intermediate, and even sporadic, and at the same time provide protection. Stopping and restarting based on seasons of risk is quite common and can be prompted by changes in individual needs, changes in routine, relationship status, actual risk, and even the ability to go to a consultation or obtain a refill. And we also wanted to differentiate it between terms that are often used quite interchangeably. And so we present here some different definitions for commonly used terms, and really wanted to point out the difference between effective use, which is having sufficient drug concentration to achieve protection from HIV infection over time, versus adherence, which is really taking medication on a daily basis to confer protection within 24 hours. And so sometimes those terms are used interchangeably and are really a result, again, of sort of copying the HIV treatment and imposing an HIV treatment lens on prevention. Next slide. So there's really a need to differentiating, making a conscious choice to discontinue PrEP, which should not be treated as the same as unintentional interruptions due to barriers in access or dissatisfaction with quality of care. And there are emerging and exciting evidence from several studies, one of them being the search study conducted in Kenya and Uganda, as well as data from analyses done on the US National PrEP program that show that modest rates of PrEP coverage can contribute to reductions in HIV infections among PrEP users. The search study also reinforced that stopping and restarting is common, and that individuals really tend to know how to navigate their seasons of risk. And in the search study, more than 90% of people who understood themselves to be at risk stayed on PrEP. It's also important to note that a key component of the search study and delivery model was providing universal access and also a flexibility, more community-oriented delivery model. So taken together, this evidence really reinforces both the need to better understand and measure impact of PrEP programs at the community and population level, while also perhaps investing in more simplified and differentiated approaches to delivery. Next slide. And demonstrating impact will be ever more important as more products are available, and with a growing number of new prevention options that hopefully will soon be available pending regulatory approval, we could see an overall increase in the use of HIV prevention methods, as we have seen with contraception. And so, we sort of, as a result of the think tank, are calling for both a standard measure of impact irrespective of product, but also recognize that M&E could be more complicated. As more products are available, we may see more switching depending on preference or lifestyle changes. There could be more simultaneous use for some periods of time, whether individuals want to use multiple products as a backup method, or due to interruptions in access, or just lingering drug levels. So really developing ways to understand patterns of use at the individual level will also be important. Next slide. And the good news is that family planning may offer lessons in both how continuation is viewed and measured. Contraception continuation and switching is much more normalized. It's not a driving factor in evaluating program success. And it's really seen as just part and parcel of program delivery that women will switch. Continuation rates are not very high. They've taken decades to even reach the levels that they are at now, and they're still imperfect. So one of the most salient takeaways of the think tank, next slide please, was to push to identify an impact measure similar to what is used for contraception. So instead of measuring continuation of PrEP over consecutive days over a certain time period, could couple years protection be adapted for HIV prevention? And that really consists of estimating protection provided by family planning method during a 1-year period based on the volume of all contraception sold or distributed to clients during that period. So it's really how to correlate contraceptive use over time with reductions in the case of contraception in unplanned pregnancies, and preventing unplanned pregnancies, excuse me. And could we employ something similar for HIV prevention by measuring PrEP use and coverage at the population level and correlating that with reduction in the number of new HIV diagnoses? So that's what we also hope to explore here today. Next slide, please. So what are some potential solutions for some of the challenges we've discussed? Can we remove some indicators that might be less relevant to HIV prevention and add indicators on impact and guidance, as well as incorporate them into population-based surveys, much like is done also for contraception? Family planning can be an inspiration and a potential model for approaching M&E, of course, with some adaptations for HIV, especially given that there's evidence that when the expansion with the expansion of the method mix, there are increases in overall prevalence rates. How do we differentiate between what is needed to measure impact versus what is needed to measure individual level outcomes and patterns of use, which can be achieved through qualitative and implementation research and does not have to be part of routine M&E, which can overburden healthcare providers and healthcare systems. And lastly, and other presentations today will delve further into this, but how can more simplified delivery, which really the field is shifting towards, and expanding delivery channels where PrEP is offered, really help to increase uptake, effective use, and ultimately impact. Last slide, please. And so these are the key questions we really want to address here today. We hope to spark healthy dialogue to hone some of these recommendations, as well as for ongoing advocacy. These questions are, what does a harmonized minimal set of indicators look like to measure PrEP progress towards both global and national targets, as well as impact? What are opportunities and challenges associated with measuring impact based on volumes of products akin to contraception? What data can really be reserved for clinical monitoring, surveillance, or more in-depth research studies that would minimize reporting burden? What is needed to forecast commodity needs? That's a reality that we need to take into account, especially as there's a growing portfolio of products that could be available. And lastly, but certainly not least, again, how do we really reimagine PrEP delivery, which is taking place and excitingly so, which may help to reduce barriers to access and therefore improve uptake and ultimately impact. Next slide. And we have a wealth of resources to share with you, and we're happy to share them after the webinar, including reports on the think tanks where you can really read in much more detail about the discussions and recommendations that emerged from the think tanks.
Thank you so much, Jessica. Yeah, thank you for setting the stage so well. And I welcome folks to put any questions or comments in the chat. And in the meantime, we're going to pass this over to Jason Reed to continue the discussion.
Thanks, Christine, and good day, everybody. It's a pleasure to be here with you. Before we transition the webinar over to colleagues that are based in the field to talk about some innovative ways to improve effective use, I'm going to make some final remarks on effective use measurement, specifically related to monitoring and evaluation, and try to make some differentiations or distinctions between monitoring and evaluation and other methods of measurement. Can you hear me okay, Christine?
Yes.
Okay, great. So as we look forward to the future of expanded menu of biomedical HIV prevention products, as Jessica alluded to, we'll be similarly thinking about how best to measure them, hopefully drawing upon examples from the family planning community and best practices that they've established over decades of implementation, and specifically not just related to oral PrEP, but all PrEP products. As we think about measuring what matters, typically we think of questions falling into three categories. These were the consensus categories coming from the think tanks. Measurements that answer questions about accountability, accountability to donors and ministries of health, measures that are intended to answer important questions related to program improvement as relates to PrEP products, most notably whether those products are being used in a protective way. And then third, measurements that answer questions of impact. As Jessica alluded to, with prevention funding constrained, of course, we have to make the case, and rightly, that the investments in prevention are resulting in the incidence reductions that are intended to continue to justify the differentiation of investment across the prevention and treatment portfolios. And so definitely having measures to forecast impact are obviously very important. So I'll delve into each of these just a little, and then again, we'll transition over to probably some more interesting and exciting developments around effective use in the countries. Next slide. So starting off on the measures for accountability, I think in most of the lived experiences of those on this call, this has to do with indicators that are reportable to donors, probably most notably PEPFAR. And PEPFAR has provided for indicators in their MER guidance 2.5. And Jessica sort of alluded to these. But accountability, of course, is all about reporting results that indicate to the donor and the Ministry of Health in the country whether or not the funding has been translated to achievement of targets as promised. For PrEP specifically, there are two indicators. They're both largely cross-sectional measures that have to do with the number of people prescribed PrEP, specifically oral PrEP currently. And you can see some details about these. I won't go into them here. Probably everybody on the call is very familiar with PrEP new and PrEP curve, but just to say that even by name, these mirror exactly the ART indicators. And as Jessica mentioned, we're largely transposed from treatment programs onto prevention programs. Even though there's some question about whether or not PrEP curve specifically, whether it measures anything that's meaningful related to expectations around continued use. And so we'll revisit that in a minute. So transitioning on from accountability indicators, which I think are probably the most straightforward, to quality improvement indicators. This all has to do with determining whether the way in which people are using PrEP is protecting them against HIV. Again, not specific to oral PrEP, but this will obviously also apply to future products, even as they're used less frequently or through different routes of administration. Obviously, we know that effectiveness is higher when the periods of PrEP use overlap with periods of risk. But it's hard to measure these things longitudinally, and it's especially hard to routinely measure individual level risk, in that it varies widely over time. However, for programs that have gone to the trouble of longitudinally monitoring client level use, as Jessica mentioned, we've seen very common cyclical use where people frequently start and stop and restart later. And there have been research studies that show that this cyclical type of use or sporadic use may not actually be random. It may be well timed to reflect periods where people understand that they need to be covered for risk behaviors. And as Jessica mentioned, the search study showed that even this sporadic or non-continuous use, as coverage increases, results in reductions in HIV incidence, which is very reassuring. When PrEP programs were first introduced, this type of non-continuous or sporadic use was not at all envisioned when the programs were designed. And so, of course, because that wasn't anticipated, the M&E systems and indicators that were chosen for PrEP were sort of narrowly focused on this ideal of continuous use where somebody would start and continue forevermore. And so as a result, there haven't been good indicators or M&E processes to account for people's changes in risk over time and consequently their changes in use over time. And because there aren't good measures of it, probably not surprisingly, providers are not adequately equipped to provide counseling and supportive measures to support this real life phenomenon of use where people start and restart frequently. And so it is very important for quality improvement purposes that we have the right measures in place so that providers are best equipped to support people in the way that they use PrEP that reflects the real patterns of risk that they experience in everyday life. Next slide, transitioning on to the last category of measures for impact. Jessica mentioned some data from the US that showed that as as PrEP coverage increased, HIV incidence decreased, and she also showed some data from the SEARCH trial that showed the same. And so the question remains, how can we best account for increased coverage and make any associations that we can to show that increased coverage of PrEP products results in decreased HIV incidence over time. I think probably the most important piece of this particular category of measurement for impact is that it doesn't really come from routine M&E. It comes from population-based, it likely comes from population-based surveillance activities and research studies. And Jessica already covered the CYP, the couple years protection, and the notion from the think tanks that that may be a good approach that we should draw upon as the menu of PrEP products expands, so that instead of trying to measure the impact of any one product, instead we're looking at the pool of individuals within populations that use, switch, simultaneously utilize different PrEP products over time, and try to account for the protection that's conferred accordingly, as opposed to longitudinally looking at any individual product's use. Next slide. So when it comes to improving indicators and M&E across these different categories for accountability measures for donors, as we begin to think of the future of PrEP products, not just for oral PrEP, but for all PrEP products, should there be a single expectation or indicator about the length of PrEP use, given that the duration that any individual is at risk is going to vary widely? It's a sort of a rhetorical question. I think what we've suggested is that because individuals experience vastly different periods and cycles of risk, that it doesn't make sense to have a single indicator with a strict definition of how long any particular individual should use PrEP in order for that PrEP use to be effective. It's far more complicated than that, and trying to transpose a single indicator onto all individuals out of convenience is probably misleading in its results. Second, we have suggested before and continue to suggest that PEPFAR replaces PrEP-CUR, perhaps with an indicator around the volume of PrEP distributed, so that we can more meaningfully begin to associate whether increases in PrEP coverage result in decreases in HIV incidence. And then just to say that longitudinal use and risk phenomenon, they may be important to measure, but they're not really accountability measurements. They really relate more to program improvement measurements. So then onto that category for suggestions, program improvement, we suggested that some programs do continue to monitor longitudinal use, specifically as new products come to the fore and people use among the mix of prevention products, either in tandem or in series. However, we wouldn't recommend that kind of monitoring be done through routine M&E, but instead through surveillance or implementation research. Next slide, last slide. Finally, on the impact measures, as Jessica alluded to, suggestion was made that donors begin to track the volume of PrEP distributed across the number of users over time, so that we can begin to formulate whether it's feasible to develop a measure such as the CYP measure for family planning, so that we can have some agreed upon assumptions to forecast impact simply based on volume distributed. And ideally pairing those data with the FIA surveys, so that we can associate increased coverage with changes in HIV incidence over time. And I'll stop there. I think maybe just a little over. Thank you.
No, you're doing terrific. So thank you so much, Jason. And I thought that was very provocative and a lot of food for thought. Welcome audience reflections on what they think, whether they think it would be good and possible to change to some of the indicators and approaches that you proposed. So we're now going to move over to Cindy Matsi, who is going to share with us some of the experience going on in country and in Eswatini and how the health ministry is evolving in their thinking about PrEP M&E to guide decisions. Over to you, Cindy.
Thank you, Kristen. Good morning, good afternoon to everyone. Thank you for inviting me to share our experience as Eswatini in scaling up PrEP. Next slide, please. In Eswatini, PrEP is currently scaled up, and we are offering PrEP to the general population, anyone who is at risk and those that may need PrEP. And we have also identified some priority populations. PrEP is provided at health facility, and it's also provided at community level. Within these structures, it is provided in the different service delivery points. So as a start, we have developed a risk assessment to identify those that had risk, and we've integrated this risk assessment in HTS. So within HTS, which is provided in different service delivery points, we are able to identify clients that are eligible for HIV testing and those that may be at risk. And for those that are at risk are the ones that we are targeting using the HTS officers. We have developed a toolkit for prevention services, which the HTS, through the training that we've done on conducting motivational counseling, they can engage the client so that they can choose a prevention method that is acceptable to them, that is also meeting their needs. And with this approach, we are promoting the combination prevention rather than to be promoting an individual interventions. So for PrEP, if clients are interested in PrEP, we have developed some questions that can guide the HTS counselors when they engage with the client, and we also have some consideration for the priority populations and then the package of services. So in that illustration, it shows the step that we follow whenever we engage a client. Next slide, please. So for those clients that will be interested in PrEP, when it was offered by the HTS counselor, they're referred to a nurse, and once they're with the nurse, we have a PrEP register, which is our M&E tool. So we have included a column which indicates or highlights the expected need for PrEP, which we have categorized with long-term or short-term. So our short-term being a client who may need PrEP for 1 to 4 months, or those that don't even know how much time, how long will they be using PrEP. And then our long-term, it's anything more than 4 months. So we are capturing this in our current register. Next slide, please. So why did we think of introducing the seasonal PrEP or categorizing our clients into the short and the long-term use? So for us, we know when we look at what we are doing for those that are on ART, we are supporting them with, to support them on adherence. Our healthcare workers, they are following them up. But then we thought this is going to be too much for them to be following everyone who's being initiated on PrEP. So we thought if we introduce this short-term, long-term, it's going to assist them to know which clients to be followed, and they may not worry about those that are short-term. However, those that are short-term, there is a package that we make sure that at initiation it's being emphasized, because you might lose the client. They might not come to formally stop PrEP. So those that are long-term, they are being included in our appointments. They are scheduled and they can be followed. Again, we are recently working on addressing the barriers that have been highlighted by our clients. We're introducing pill bottles because some they've complained that The PrEP ARV bottles are similar to those that are used by those that are positive. So we're introducing pill bottles for those that are not comfortable, or else they can use labels, those that are not, don't have a problem with the current bottles, but it's the labeling. So with that, we may know that the long term, we can give the pill bottles. Those that are planning to have a short term, we may see which is best in case they do have the same barrier. Also, it helps because we know that the reason for PrEP are personal, and we don't expect all people that are initiated on PrEP to use PrEP for a very long time. People can stop and start and stop. So that is expected, as it will depend on their risk. Next slide, please. So how can we measure? So Eswatini, we have included the categories, the short-term and the long-term in our guidelines. It's already in there. And as you've seen our register, we've also included the short-term and long-term in the register. And these tools are being tested. We are piloting them currently, and we are going to analyze the data and see, but the intention is to include this short-term, long-term in our electronic database. So the focus on analysis will be through electronic records, especially now that we are having the pandemic of COVID-19. Next slide, please. So how do we plan to use this data that we are currently collecting? With the seasonal risk, PrEP continuation, when we look at it, it should adjust based on this short and the long term. When we look at our continuation use, the rates, when you look amongst those that will be taking PrEP for a long time, it looks good. But then when you adjust for the overall, it is low when you start to adjust for those that are taking it for the short term. So as you look at going forward, you'll see that there is a drop. And this could also have an issue in terms of our counseling for PrEP if we have a steep drop on month 1 for those that are short term. So it also helps to better identify where we need to strengthen in our service delivery, where are our people dropping off and why are they dropping off, both for the short term and the long term. We look at them separately. Also, the risk period should guide healthcare workers in terms of the follow-up, as I've already mentioned, so that they know which line to be followed. They can also plan their refills and also the expectation in terms of appointing these clients in our tools. And this is also a data that will assist us as a program, as a country in our forecasting and quantification to looking into the projected need based on the long-term and the short-term data that we already have. Next slide, please. And then how do we look at restarts? Shifting the mindset to short and long-term risk needs, it changes how we think about the restart. It's better it better aligns with why people are taking PrEP. Restarting PrEP it's not bad. Healthcare workers, they just need to embrace. We know when we introduce this, our healthcare workers, they've always complained that clients are stopping and starting. So we always emphasize that it's not bad for PrEP for clients because their risk, some of their risk is seasonal, so it is open for restarting and stopping. Also, knowing someone's season of risk through counseling allows their healthcare workers, as they engage with the client, to discuss further so that the client, they may understand they are starting, they may know when it's good for them to stop, and also be thinking when they can restart, because they are looking at their risk as individual. Also, it will improve discussion around the risk, the seasonal risk. It allows for better discussing the barriers that need to be addressed prior to restarting the client. May we have the next slide, please? Do we need a prevention cascade? This one is a very complex one. It is challenging. We are discussing it as a country, as we can't document cohorts the same way as we are documenting for ART or for treatment. So we can't always confirm if our clients are using any prevention methods. That's the difficult part for it. But what we can do, what we are currently thinking, is that we can be able to document the services that we are providing, especially where we do have data in terms of the messages for prevention, the condoms, the PrEP, all the prevention methods. And if possible, it will be able to identify where people are receiving their prevention services, the platform. If we are reaching people, though we might not get the clear picture of our coverage. While we might not be able to document the impact, we can use the data to hold people accountable, especially our implementers, to see that they are promoting the prevention services for our negative individuals that are at risk with the prevention options that we have. For those programs that are able to track clients longitudinally, we could start to look at the programs and see if there are any links. Next slide, please. So I've borrowed this slide from our key populations program, which is currently implemented through FHI 360. We've just introduced the decentralized drug distribution in relation to the COVID that we are currently experiencing. So in regards to our service delivery, we are offering the DDD clients, which we have a nurse that is responsible for line listing the client, and then it will be offered to the client. But then the client, they have an option of choosing where they can pick their drugs. It can be home-based, where we have our outreach going to these individuals, or in their preferred platform. Since I've said that we are providing our services even for key populations, they do have their specific site and also the outreach. So we've also integrated the DDD in other services like the ART, the family planning, the TP, and the NCDs. So you can see from the graph that there has been increase ever since we have integrated PrEP into the other decentralized drug distribution models. May we have the next slide? And other strategies to keep people on PrEP, we are addressing their barriers, as I've mentioned, that they've highlighted that some they're complaining about the same bottle of ARVs that is used by those people that are living with HIV, and the rackling of the drugs because of the space between the space in between the drugs. So we are currently introducing the pill bottles that they can use to store their drugs, and also the pill bottles, pill labels that we can put on the original bottles for those that their problem is the labeling. So these are the strategies that we are currently introducing as a country to try and address the issue, so that we are able to keep those that are continuing to need PrEP on PrEP. So I think this is supposed to be my last slide. So thank you very much. And thank you to FHI 360, Laura, who supported me with the presentation. Thank you.
Thank you so much, Cindy. I think that Eswatini is really very forward-looking in this, and we have a lot to learn from the different modalities that you're exploring to try to get at the lack of continuous PrEP use. So we do have some questions that have come through, but I'm going to hold them until we get through our next speaker and then come back for an interesting discussion. Now we're going to turn this over to Nitya, who's going to share some of the efforts to enhance PrEP continuation in the EPIC project in Thailand. Over to you, Nitya.
Thank you, Christine. And thank you very much for giving me the opportunity to share some thoughts around the key population-led PrEP service program in Thailand. And this is a program supported through USAID linkages and now EPIC program. Can you have next slide, please? And our KP-led PrEP program has been made feasible through simplification, which is to make the steps less complex, and through differentiation, which is to for us to be able to identify those clients whose service may need to be intense, and then those clients whose service can be made light, and then through lastly demedicalization, which is to shift some tasks from doctors and nurses to lay providers. Next slide, please. And in Thailand, we started this KP-led PrEP program as part of the Key Population-Led Health Services, or KPLHS, since 2015. And KPLHS was established to demonstrate that a set of HIV-related and sexual health services can be and should be designed by key populations themselves, so that we can ensure that services are needs-based, demand-driven, and client-centered. And these services are also co-delivered by trained and qualified lay providers who are often the members of the key populations. Next slide, please. And KPLHS aims to fill in the common service gaps faced by key population clients. And we aim for the services to be accessible through flexible operating hours and location in hotspot area. And for the services to be available and tailored according to the need of each key population. And also to make the services be acceptable through non-judgmental and stigma-free environment. And lastly, for the services to be of high quality. Next slide, please. And the KP-led PrEP program in Thailand has been designed in a way that it is simplified and demedicalized to allow PrEP service to happen on a same day basis. From what you can see from this slide is that once the client comes into the KP-led clinic in the community, they will have the counseling, blood draw, and HIV testing conducted by the trained lay provider. And then that lay provider will send the HIV negative test result via an online chat application to a doctor who is in a remote hospital. And then the doctor will review the HIV test result and then approve PrEP prescription, so that the lay provider in the clinic can then give out the first bottle of PrEP or 3 or 6 bottles of PrEP refill to the client almost within the same hour of the client coming into the clinic. Next slide, please. And over the past 5 years, the KP-led PrEP program in Thailand, which is very similar to what we have seen in a few other countries in our region, such as Vietnam and the Philippines, has contributed, the KP-led PrEP program has contributed to the largest proportion of PrEP uptake in the country. And from this slide, you can see that 53% plus the top 13% up there, altogether 66% of PrEP service in the country are provided through this KP-led PrEP program. Next, please. And so this large contribution has led to a few infectious disease doctors in our country started to help advocating for the domestic financing of the KP-led PrEP program, as well as the whole KPLHS, in order to sustain the program through this direct paying from the government to the community-based organization for their service provision. Next, please. And Next slide, please. Yes, thank you. So here, since June 2019, we have introduced the PrEP effective use and the retention in prevention service approach to our KP-led PrEP program. And this was done through a refresher training for our lay providers who are already those who are trained and qualified PrEP providers who usually will use this life steps counseling in a way that they support the client to make a plan on how to integrate PrEP into their daily life, and then to be able to assess their self-efficacy to follow the plan and or to identify the need to revise the plan. So it's not too challenging to change the counseling approach of these providers, since they are already a forefront providers who understand very well the challenges around PrEP continuation. Although this is not automatic because these lay providers are mainly those who are pioneer PrEP providers in our country who were kind of unofficially tasked to demonstrate the most beautiful PrEP cascade in order for us to use the data to convince our government a few years ago to include PrEP under the universal health coverage. So it's more of kind of how we can upskill these lay providers to now being able to empower the clients to self-identify the needs to either to stop PrEP or to switch in between daily PrEP and event-driven PrEP, or to restart PrEP. As well as at the same time to ensure the clients that there is continuous support available at the clinic regardless of PrEP use, and that there are so many other benefits of regularly attending the clinic for HIV and STI testing. So the two graphs here demonstrate the PrEP effective use data among our MSM and transgender women clients. On the left side, you can see that more than 99% of MSM clients who return for PrEP at month 1 and month 3 reported PrEP effective use defined by having at least 4 tablets of PrEP pill per week during risk, which mainly means during condomless sex, or the correct use of event-driven PrEP. This is for men who have sex with men population. For transgender women, you can see that more than 95% of transgender women who came back reported PrEP effective use as defined by 6 taps per week, at least 6 taps per week during condomless sex. We have not yet looked at the retention in prevention service data, although I'm pretty sure that we can do that, but we have not had a specific request to do so, and during these very difficult times. And so that will be what we will do soon. But later in 2019, we also introduced this PrEP effective use question into our national PrEP database. However, the reimbursement system, which is linked to the national database, might have not yet encouraged the implementation of the retention in prevention service approach in a way that there are currently different reimbursement rates for PrEP counseling versus routine HIV counseling, where PrEP counseling gets 3 times higher reimbursement than routine HIV counseling. So providers mainly in the facility-based hospitals may still want to kind of try to make people continue on PrEP so that they can reimburse for PrEP counseling. Next slide, please. So over the past 5 years, we have demonstrated that KP-LHS contributed to more than half of HIV testing and more than half of PrEP uptake among MSM and transgender women populations in Thailand. Next slide, please. And we use that data to advocate for the institutionalization of KP-LHS through legalization of clinical roles performed by lay providers through an announcement of the MOPH regulations, which is endorsed by the 3 professional institutions. Next slide, please. And the clinical roles that the KP lay providers can play include those beyond pre and post-test counseling, and also includes those sample collection through finger prick blood collection and oral swab, anal swab for HIV and STI testing, as well as the role to perform the point of care testing, including the reading and the reporting of test results. And lastly, it also includes the role to give drugs as prescribed by health professionals. So these drugs include PrEP and PEP and ART and oral STI treatment. Next slide, please. And the Engage team under IHRI has been playing the main role in capacity building and certification of KP lay providers in Thailand. And through this capacity building and certification process, KP lay providers are those who are nominated by community-based organizations themselves to ensure that once they complete the training, receive the certification, they will be committed and supported to perform clinical roles. And these potential lay providers will then go through the didactic training sessions and will need to pass 80% test score before they can enter the practicum process, which include case collection. So for example, to be able to be certified as PrEP providers, you will need to demonstrate your capability to provide PrEP initiation service to 5 clients, plus another 5 PrEP follow-up service. Then you can request for in-person assessment. And if you pass that 80% test score for the practicum process, then you will receive the certification. Next slide, please. And right now we have 350 people who already passed the didactic training course, and 106 who were already certified to provide the extensive clinical roles of lay providers. Next slide, please. I think this is the last slide. So to conclude, at least in Thailand, we have demonstrated that KP-led PrEP is the way to simplify, demedicalize, and differentiate the service to ensure that the service is client-centered and needs-based. And we have also seen that institutionalization of KP-LHS is feasible through legalization, through certification of capacity building, and also through the domestic financing in order to scale up and sustain KP-LHS. But we really need sincere and continuous policy commitment. And lastly, we also feel that the measurement of retention in prevention service and the measurement of PrEP effective use can be made feasible and will likely be enhanced by reporting system requirement as well as the reimbursement system. I think that's my last slide, and thank you very much.
Wonderful. Thank you so much, Nitya, for that overview. We are actually going to take a break now for some discussion and Q&A, and then we will, after that, we will turn over to our WHO colleague, Robin Schaefer, to hear what WHO is thinking about PrEP indicators in the future. But let's pause for a bit of discussion. I think most folks have seen an active chat around this issue of how is cycling of PrEP different from ED PrEP? And when is one or the other appropriate? So I do think this is an area where there is confusion, and I would be interested to hear our panelists reflect on this topic. I'm wondering if I could maybe start with Jason.
Yeah, Christine, I'm cross-covering something. Can you come right back to me? Sorry.
Sure. Yeah. How about, who else would like to tackle this topic? Robin?
Sure, and I think we already had some answers to this in the chat, that there needs to be a clear distinction between event-driven PrEP and daily PrEP, because current guidance suggests event-driven PrEP only for cisgender men who have sex with men. And as Heather Marie was saying in the chat, this is something we are currently looking into, whether that can be extended to all cisgender men, but there is certain evidence that suggests that it's not appropriate for vaginal sex or for transgender men who have vaginal sex. So that's an important distinction between that and what we hear about here in terms of daily oral PrEP, which is cyclical, and people take it during certain periods of risk and which changes over time, but still requires some form of continuation. For event-driven PrEP, we don't need that same level of continuation. We need we have the formula of 2 + 1 + 1. That's all we really need for protection in this particular population where it's suggested for. Whereas for other populations, we do need some more longer periods of pill taking to achieve a protective level. But that level can be achieved fairly quickly, and then people can stop when that risk is no longer present and can restart later. But it's an important distinction to make.
Thank you, Robin. I just on the ED PrEP side, can I just clarify? I think the guidance does allow for trans men who have anal sex to also use ED PrEP. So, and it's not just cis men, but trans men who have anal sex, but not frontal vaginal sex. So I think that frontal vaginal versus anal sex is one of the distinguishing components. But I think maybe the confusion is what do we mean about when we talk about people cycling on and off PrEP, like with the ED PrEP. So it's very specific, the 2 + 1 1, you need to take PrEP for 2 days after your last exposure. What we have seen in the guidance for women has been, that you need to take PrEP for up to a month after the last exposure, although discussions are underway to reduce that to, a more general 1 week after last exposure. So if people are cycling on and off PrEP, what does that length of use look like? What is an appropriate length of use on PrEP for the general population, not talking about the specific role of ED PrEP? Anyone want to jump in on that one? Jason?
Yeah, sorry, I'm back. Yeah, so back to, in answer to your question, and I want to allude to something I mentioned. You said, what is the appropriate length of use for the general population? There is no one answer, right? I think we can come up with examples of what it might look like to sort of differentiate. I think what you're asking is, could we come up with some illustrative examples that would more clearly differentiate ED PrEP from cyclical use in the general population? So for instance, MSM using ED PrEP, that's really clear already from the WHO guidance. They would take 2 pills before sex, 2 to 24 hours before sex, and then 2 pills 24 and 48, or 1 pill 24 hours later, 1 pill 48 hours later. So that's pretty clear. I think the example of cyclical use in the general population that's illustratively different, for instance, would be if an adolescent girl or young woman is anticipating going home from a school holiday during the month of December, she might get a PrEP prescription 7 days and start using PrEP 7 days before returning home, and then use PrEP for the duration that she's at home for the holiday that she anticipates the period of risk. And then after the last sex act, continue using currently as we understand it for 28 days, but then stop when she's back at school and no longer anticipates risk, if she doesn't anticipate risk. And if she didn't anticipate then being exposed again until returning home 6 months later, for instance, or 3 months later, then she could restart a week before the anticipation of the risk and use the PrEP, the duration of being at home. I'm only drawing on that example because it's one that I've commonly heard in Kenya, reported by adolescent girls and young women who have used PrEP cyclically, but I'm sure there are others on the panel who have real life examples of clients they know that have used PrEP also in a cyclical nature. Again, this would be very different from event-driven PrEP, but it's also not daily use continuously, indefinitely for years, because it's an example of, you know, an anticipation of risk that happens every 3 or 6 months, that's specifically tied to an event, to holidays, to traveling home or traveling somewhere else, just as an example.
Thanks, Jason. Josie, you wanted to comment?
Yeah, I think this is a really interesting conversation, and I do imagine that in real life, I'm sure we likely have women using PrEP in a much more intermittent fashion, of maybe using it 1 week, and then a few days the next week, and then maybe a week off, and then they remember and they use it another week. I think what we don't have is the data around whether or not those women are having instances that might put them at more risk and are seeing protection. And so we don't know enough to say what that looks like. But I would imagine in the real world that there are situations that we are seeing almost a more, if not following the specific event-driven regimen, a more perhaps sporadic use patterns, just given the realities of people and their use of medications and pill taking. It might be interesting to understand further whether or not, you know, if we could observationally understand what that impact actually looks like. Over.
Thanks, Josie. And I think Jhpiego has some data that they have done looking at various use patterns. I think one of the big challenges is going to be as we come to accept and acknowledge that cycling is normal for PrEP use, how are we going to measure that? It's going to be complicated. Chris Akolo, you wanted to comment?
Yeah, thank you very much, Christine. I just wanted to share, you know, something we're seeing now in a few of our programs, particularly within the context of U=U and like sporadic or intermittent PrEP use. So in situations where you have a discordant couple, and maybe due to one reason or the other, you have the HIV positive partner becoming detectable. You know, we've had instances where, you know, the HIV negative partner decided to just go on PrEP for a short period of time until the individual becomes, you know, suppressed, and then they stop taking PrEP. But I think overall, once we get to the point where the duration or the number of weeks or days for PrEP use following the last exposure is reduced, maybe from 20 days to 1 week, I think it becomes easier for us to be able to monitor that. So right now it's complicated because if I got exposed 2 days ago and I have to continue taking PrEP for another 26 days, by the time I complete that, even before I complete that, I'm probably going to have a need to be on PrEP again. So sometimes, you know, in reality, it's actually very difficult to separate that from individuals who continue to be on PrEP for a longer period of time because of that 28 days period to continue PrEP. But within the concept of U=U, we're beginning to see clients now going back to PrEP, you know, just because the HIV positive partner has become detectable or is no longer undetectable. So I just wanted to, you know, to share that as well. Over.
Thank you, Chris. I'm going to go to Rachel and then to Robin Akel.
Yeah, this is really interesting discussion. And of course, the real world is nothing like what WHO recommends in guidelines. So, but just to respond in the chat, we do suggest that 7 days for women is prior to you know to sex for PrEP use is what we recommend, and that's just because that it takes a few days to get the levels up to a protective one, and that's very much been done in PK studies. We are really hoping that we will be able to reduce the post, you know, the stopping to 7 days as well, to be much more reflective of what people are doing. People certainly, you know, we have anecdotal and now some other findings that people do not take 28 days after their last sexual risk. But to Josie's point, I think it is, you know, what's really tragic sometimes is that, you know, people will take PrEP, they'll stop because they don't have any risk. Then they will have a risk and think about restarting. And what we don't want to do is miss the opportunity of providing PEP, because starting somebody who has had a recent exposure thinks, oh my goodness, I must go back on my PrEP. It would be better really to start on PEP and then transition to PrEP. I think, you know, it's those clear messaging, and I don't think we have enough PrEP to PEP discussions for that group, because, you know, it's often relatively difficult to anticipate when you're going to have a risk period, and often people, you know, think about it once they've had a potential risk.
That is a very, very important point, Rachel. Thank you for that. I think there's a lot of confusion about the timing. So, and maybe part of it is that we talk about the timing that you have to be on PrEP or stay on PrEP after exposure. We've been talking about both what are the current guidelines and what are some of the considerations for the future. Maybe we just help to just talk about what the, you know, the current guidelines are, that for men and women who are engaged in
I mean, I don't know whether it's just me, Christine. I can't hear you anymore.
Christine, we lost you for a second.
So maybe just I'll step in for Christine. At the moment, of course, you know, we do know that the 211 is highly effective for men, and so therefore the rationale for a seven day lead-in for men is not needed. The 2 tablets before starting, and then the 1+1 after stopping, and that applies to whether you have whether you're taking event-driven or you know, seasons of risk type PrEP. And maybe we need to come up with a better term that really captures those periods, which obviously what is happening a lot is that people will take for a week or for a month or for 3 months or whatever when they have those periods. So for that's really quite clear. For women, of course, at the moment, we say 7 days before, and hopefully we will say 7 days after. And that could be that a woman would only need to take PrEP for 2 weeks if they've just got, you know, a very, you know, that they're just seeing a boyfriend on one occasion and then they're going back somewhere else. And, you know, that there are lots of these examples, as Jason says. I mean, there was a very nice project that ICAP did in Mozambique, where, you know, miners' wives took PrEP during their periods that their partners were coming back over the holiday period. So again, a short period when they saw their partners. Often it was a time when they maybe thought about having a you know, conceiving. So there are lots of really good examples of this short period, and we want to make it as easy as possible for people to do that. So you know, ideally, as I say, 7 days before and hopefully 7 days after is going to be what we suggest for women.
Thank you, Rachel. I'm glad my microphone went out because you were much more eloquent than I was anyway. I want to move us. We have a few minutes, just 2 minutes left of Q&A before we're going to go to the WHO presentation. So I wanted to just give, I wanted to ask Robin Akel if she wanted to comment back on the measurement issue for these varying patterns of use. How would we measure? And then we'll go to Jessica.
Thanks, Christine. Yes, I just mentioned in the chat, I think because we're seeing so many different patterns of use, and it's probably nearly impossible to really measure those, you know, in a cohort type fashion or in any kind of linear fashion on an individual basis, just given the numbers that we're trying to now reach of people who need PrEP. It's likely better for us, as Jason and Jessica presented on earlier in the webinar, to move towards a more family planning based approach to measuring PrEP use, which could also you know, take on the new products as well, so that we're really thinking about, you know, how much product is going out, and if our services are flexible enough and accessible enough, people will be able to self-select when they really need a given product. And you know, even though they may not be using it, if we are reaching a large number of people, those patterns of use will kind of, I'm probably not being very articulate. Jason, please jump in. But they will, you know, they'll sort of even each other out, balance each other out. That's the word I'm looking for, to where we're still reaching an impact. But we don't necessarily need to be measuring, you know, whether someone's doing 2-1-1 or a week on, a week off kind of pattern, or a month on, a month off pattern. Over.
Thank you, Robin. And over to you, Jessica.
I was going to say something very similar, sort of really distinguishing between what is needed to measure overall coverage and impact of PrEP, and you know, irrespective of products. So I see somebody wrote about, you know, preparing populations for new products, and so, you know, that would be, you could disaggregate by product, but you know, it wouldn't necessarily be by product, and so and versus the need maybe for some more targeted, rigorous research that really looks at patterns of use, but that those research studies could be, you know, again, very targeted and much on a much smaller scale, if there's a need to really understand what are primary reasons for discontinuation, in order to then translate that into strategies for providers, for provider counseling, or really to identify individuals who might be more susceptible to stop PrEP very early and before it confers protection.
Thank you, Jessica. Yeah, I think this whole conversation has really highlighted the need for more conversation on this very important topic. And in fact, there was a question in the chat about whether we have a regular discussion group. So I think I will, you know, I know this think tank on effective use is continuing, and we will look for ways to engage more broadly on that. But given the time, let's turn this over to Robin Schaefer from the WHO to share some thoughts on the future.
Thanks very much, Christine, and thanks for inviting me today to speak about monitoring of PrEP and our kind of WHO thinking of current indicators, but also future plans. And if you go to the next slide, just to take a step back, you know, we all know this, but it's always, you know, important to keep in mind and like remind ourselves what tremendous increase there has been in the world in the number of people who have received oral PrEP at least once a year, as shown on this graph. And despite the disruption by COVID-19, this trend has continued last year. And if you go to the next slide, without going into much detail here, we do expect this trend to continue at least at the current rate, or even at an accelerated speed. So if you go to the next slide, how do we know this? We know it because there are people out there who are implementing M&E for PrEP. So some people, to whom I'm very grateful, are collecting data on this. And, you know, broadly speaking, as we heard today, what are the kind of goals of M&E? They are to measure results, improve performance, identify trends, increase accountability. We heard about that today. But with all that, if you go to the next slide, we need to keep in mind that there's a balance between, on the one hand, the information we gather and that helps us to achieve whatever goals we have in our program, against, on the other hand, the burden this places on the programs. And I'm going to come back to this balance in a minute. But if you go to the next slide, just very briefly, in terms of WHO guidance on monitoring for PrEP, there are two documents I will refer you to. The one hand is the module on monitoring and evaluation in the WHO tool for implementation of PrEP. And then there are the consolidated HIV strategic information guidelines. And on the next slide, you can see the indicators that are suggested in those documents. On the top, these are the 4 indicators that are mentioned in the implementation tool guidance, which was published earlier. And then all of these 6 indicators are mentioned in the consolidated HIV strategic information guidelines. On the left-hand side in yellowish, these are the indicators considered in the SI guidance as the core national indicator. So it's similar to what we talked about today. It's about uptake of PrEP, continuation, and current number of people on PrEP. And then there are additional indicators suggested on the right-hand side in gray on toxicity associated with PrEP use, HIV positivity among PrEP users, and then there's also an indicator on STI screening. So what are some of when these guidelines guidance was released at the time, this was intended to be kind of a unifying or standardizing framework for gathering data on PrEP. But what are some of the issues around these indicators? And some of that we already talked about today. And if you go to the next slide, there's the cyclical nature of oral PrEP use. We discussed today that people go through different seasons of risk, and what we are really interested in is effective use of PrEP. So taking appropriate levels of PrEP during periods of risk. And I think Jessica was saying that effective use doesn't have to be continuous use. And on the next slide, it's related to that. We just touched on the whole issue of event-driven PrEP for men who have sex with men, which is inherently about stopping and starting depending on needs. Again, this is not something that would be traditionally be captured in a measure of PrEP continuation. We're not expecting people to take PrEP continuously. On the next slide, another challenge to these measurements, which we think about going forward, is on the next slide, the emergence of new PrEP products. So WHO recommends the dapiving ring now as an additional HIV prevention option, and there are more products in the pipeline. Some of them are very long acting. So we need to think about how do we measure PrEP continuation more broadly in context of these products. Finally, on the next slide, we also need to consider differences between these indicators and what they actually mean for PrEP need. Number of people on PrEP at any given time, or people who continue, may not actually reflect the number of people who need PrEP, because that's depending on estimating populations in need, which is challenging. And all of that is related to target setting for programs and how do we actually set those targets. If you go to the next slide, so that were just some challenges we heard a lot about today. So it's just a summary, I think, of today's webinar. And all of this, all of these discussions here today happen in context of overarching trends in PrEP service delivery towards more differentiated, digital, simplified, demedicalized, and integrated services. And within this context, how should we think about PrEP monitoring, and what about simplifying PrEP monitoring? And that goes back to this balance I mentioned earlier between what do we need to know, what data do we need to collect, and the burden this places on programs. And with burdens, there are costs attached to it, that creates barriers to implementation and so forth. So if we want to simplify PrEP monitoring, we need to identify what's the most essential piece of information, data we need for PrEP monitoring. And that may be that we only need to know the number of people who are currently on PrEP or on PrEP in a given year, or some others today suggested that we only need to know the amount of PrEP dispensed or distributed in a certain time period. And of course, for all drugs, serious adverse events should be monitored. But do we need more than that? That is the question. What about other data? We talked about the PrEP continuation indicator that's currently suggested. Is this indicator any useful? Are we actually using it to improve our programs, or is it maybe even harmful? Because the indicator is not intended to measure performance of programs really, because it's not corresponding to the realities of PrEP use. And then, in addition to this essential monitoring of PrEP, there may be other indicators that are useful to collect data on, but there may be other ways to collect that data. Now, Jason spoke about, using longitudinal measures for, effective use or understanding the kind of seasons of risk, and that there may be other data sources that are more appropriate for this kind of M&E. For example, the FIA surveys, DHS, or other data that could be more useful. For WHO, we are currently developing guidance on simplifying oral PrEP service delivery more broadly. And that will, of course, include questions on the PrEP monitoring we just spoke about. So as part of that process, what's very important for us, and I know we're running out of time, is to find out what you guys here in the audience are thinking. What are you doing in terms of in actual PrEP programs? So if you go to the next slide, we have a couple of questions here, which you can pull up the first poll. It's just to really find out from you, what is the first question here, what are the three most important aspects of PrEP use to monitor? So if you just take a minute, go through this list of things to monitor and take the three things you think are most important. And I also invite you, I'm not reading the chat simultaneously, but I invite you to provide further comments in there on what you think is actually truly the most important thing to monitor. I don't know, Camille, I don't know, I don't see the results coming in.
They are coming in. We have about over 20 responses now. Hopefully we'll get more. You're not seeing the...
I'm only seeing the poll, but not the results.
Yeah, it won't let you click, Robin Akel, because the panelists cannot participate in the poll.
You can send me your opinion, Robin. I'm very interested.
Yeah, so none of only this is for attendees. We have 50. We have right now there are 160 attendees on, and we have 56 responses, so about a third.
Maybe in the interest of time, should we move on to the next?
Yeah, do you want to see the results?
Yes, maybe very briefly. Oh, it's a very diverse set of responses. I'm not sure we should have allowed people to get three options. But I can't see it kind of disappeared. I think the most common answer was, yeah, at the bottom, they're actually on coverage of PrEP among priority populations. And second was HIV positivity rate. So that's very interesting. Just for me, can we save these results, or they're going to disappear when we move to the next question?
I don't know, so I'm going to.
I just took a screenshot, so I can.
Fantastic.
Okay.
Great. Let's move on to the next question. We don't really have time to go into these results, but we're going to look at that later. So just briefly go to the next question and poll, which is about this question about effective use, which is a fairly complex topic as we talked about today. And I want to know from you, is there any, are you measuring effective use in your program? Yes, no, don't know. And we heard about an interesting example from Thailand, how they're using effective use in their programs by speaking about PrEP use during periods of risk, during periods of condomless sex. Maybe give it another 20, 30 seconds. I can't see the results, but my guess is it's no. Yeah, okay, actually 30% of you say that you are measuring effective use. And that's very interesting. And again, I'm encouraging you to provide feedback in the chat if you can, because this is very helpful for us to know, like, how do you measure effective use? How do you define it? So if you go to the next question. goes to the question of adverse events and toxicities related to PrEP use. Are you measuring those in your program? And we have one more question after that. I know we're running out of time. If you have a good quorum. Excellent, thank you. So about half of you say that you are measuring toxicities and any adverse events. So that's also 40% not measuring that. Thank you very much. And the last question, please, is about PrEP need I touched upon. Has there been a PrEP need estimate that you use in your program to establish targets for PrEP? Another 10 seconds, and I'm going to wrap up because we're at the finish of the webinar. Thanks. So about half of you have done that. That's great to know. Can you just go to the final slide? I thank you all very much for this. It is extremely helpful as we're going to look into this some more. And I also thank my WHO colleagues who contributed to this presentation, and most importantly, to all of you who make PrEP a reality. And as said, we are getting this feedback from everyone who's implementing PrEP in the real world. And we want to understand your thinking about M&E or for PrEP. So please provide any further comments or also questions to me by email or write them in the chat. Thank you very much.
Thank you, Robin. And if you could go to the next slide, thank you. So that was a very interesting session. Clearly not enough time to discuss all of the complexities involved, and we will look for other ways to engage on these topics. I just want to give you a heads up that that the next webinar is actually going to be a WHO-sponsored global PrEP webinar on July 7th, and then you can see the rest of the sessions going forward. In the meantime, a huge thank you to our speakers and panelists for participating today and for their thought leadership in this area. With that, I wish you all a wonderful day, evening, and look forward to seeing you again. And if we had a little music, we'd do a dance. Take care all.